morning, everybody. We'll give people a couple minutes to sign on and then we'll dive in so we can get through all our material for today. Okay, so as people are coming in, just to remind you, your first exam is on Thursday. So what you're gonna do is log into the Zoom, and you can do what you all are doing right now, leave your cameras off. I don't need to be one of those creepy people that's like, show me all around you, show me your lap. I trust you all not to cheat, and I hope that you won't violate that trust. And then I will open up the test on Blackboard. You will click through and take it that way. But I will, basically I'll mute myself. And then if you have a question, you'll be able to either ask in the chat for everyone to see, or when you chat, you can also choose just to ask me something. And the only time I'll unmute is if I've discovered there's like a typo that everyone needs to know about. So like last semester, I accidentally put the right answer twice on a question. So like half the people who answered it correctly, we're gonna have it marked wrong, right? So I just unmuted to let them know everyone will get the point for that question. So it is 20 multiple choice, and then 10 fill in the blanks with Blackboard calls it matching because there's a word bank. And then there's a short answer, like a paragraph or less, that you get to choose one from two options. And then there is a longer essay, and within that, it's still a short essay though. I'm not expecting pages and pages. And within that, there are options of what you choose. So, you know, let's say I asked you about, you know, model, since we talked a lot about that, you would get to choose the model you talked about rather than being like, you have to talk about psychodynamic and bio, right? Like, because you might not remember one as well. So my biggest tip, especially on the short answer and the short essay, is to make sure you're answering every part of the question. So I often ask people to compare and contrast things. And so when I ask that, and I try to make it clear in my wording, you need to say not only how they're different, that's contrasting, but you also need to say how they're similar, that's comparing. And again, that will be clear. It'll be clear where the points are coming from. If you don't answer a part of it, like if you skipped, let's say, the comparing, even if the rest of your essay is great, I can't give you the points for the part you didn't answer, right? So that's the biggest thing, is make sure you're reading and checking off sort of that you're answering every part of the question. Typically people fit this in to the hour 15, no problem at all. What I discovered last semester is for some people, it's harder to take a test on Blackboard. I don't have classes after this class. I don't even know, let me look real quick, but I don't think I have even any student appointments scheduled right after this. No, I don't. So I'm actually gonna block out some time for y'all. And I'll just say I'm free. So if people need to take longer, I usually give like 15 minutes longer if you need it, just because I acknowledge that like you might be in your dorm room and your roommate's home and doing stuff, or if you're at home, like your cat could be knocking stuff over, right? So it might take you longer than if you were sitting in a quiet classroom. So my biggest tips for these exams: use the review sheet to guide your studying. The way I used to study, this doesn't work for everybody, but I used to rewrite my notes just because for me that helped like get it into my brain. You know, if you know someone in the class, quizzing each other can be really, really helpful. And you can either do that in person, socially distanced, or, you know, over a Zoom or something like that. heck, you couldn't even text it in this day and age, right? Give me the definition for this. So I am very open to any emails about questions that you have. And also I always tell people, this first one, you're just trying to figure out how I'm testing you in this class. And don't forget, you have 4 exams. So if this one doesn't go as well as you want, I know some of you are perfectionists, so like a B would be not as well as you want. I understand, that was me, right? Don't sweat it, because then you'll get my system and you'll do better throughout the semester. That's almost always what happens with folks. So any questions about the exam before I jump back into our lecture?
Will we get our results right at the end of it, how most Blackboard quizzes are?
So I think it will give them for you for the multiple choice, but I have to hand grade the essays. So you probably won't get them until like Sunday, because that's usually when I set aside a block of time to grade.
Okay, thank you.
Yeah, good question. Alrighty, well, keep thinking of questions while I pull up the PowerPoint, and definitely feel free to throw them in the chat if you come up with one while I'm talking here. I'm just opening the chat in case y'all need to ask me questions. I'm gonna go ahead and get myself set up here. Alrighty. Okay, so we were talking about projectives, right? And now we're going to start talking about personality inventories. So personality inventories have a ton of research behind them. Sorry, this is almost too high. You're seeing more ceiling than me. And so these are pretty widely accepted, and they're used not only in like a client is coming to see you for therapy type of ways, but they're used in our criminal justice system. They're used for people who are screened for certain jobs. So I believe starting this week, I'm talking to my psych in the law class about how police officers are screened before they get their jobs. And often they have to take one of these as part of that. So these are really widely used. Also, we use these in research quite a bit as well, because these have a lot of research behind them already. Whenever we do research, we want to use things that we know are going to work, because otherwise we sort of wasted that time and money and effort, right? So we tend to use these things. So the personality inventory is designed to measure broad personality characteristics. It focuses on behaviors, beliefs, and feelings. And it's usually based on self-reported responses. So typically you're either in front of a computer or you have pen and paper and you're just answering questions about yourself. And so sometimes these are like on a Likert scale, which is one of those scales that's like, 1 is not true of me, 7 is very true of me. You've probably seen those before. Sometimes they're like true, false. Sometimes you pick from a set of statements which one describes you the best. So those are personality inventories. And one thing that's really important to notice is that, we have a lot of BuzzFeed quizzes and other internet quizzes out there in the world now. And those are fun. Don't get me wrong. Like, I enjoy taking those just like the next person and finding out, like which Schmidt's Creek character I am. I'm David. Woohoo! But they're obviously you wouldn't want to use those in a clinical setting. And that's what this comic on here is making fun of. So when I was in college, it was this site called tickle.com that just did quizzes like BuzzFeed. And then they were on Facebook for a while. Like I remember a Facebook one I took once that asked me whether or not I was a hamster, but hamster was spelled wrong. So pretty quality. So anytime we use something in a clinical setting, so we're going to use it to diagnose someone or make decisions about them, like child custody cases, things along those lines. We want something that has such high reliability and validity. So for reliability, we measure its from like a 0.0 to a 1.0. And typically for something you're going to use in a clinical setting, you want 0.9 or above. You want something that is really, really good, because again, you're making decisions that could change a person's life, right? So you want to make sure you're not effing that up. All right, so the first one I'm going to talk about is one that I personally have used a lot. I actually just did a training for this last semester because they just came out with the MMPI 3. And so, but I learned the 2, and this is going to be mostly about the 2, just because a lot of people are still using that one. So if you go out and interact with someone, I believe I was on like the first training for it in November, most people will still be using the 2. So this is the most widely used personality inventory. It has years and years of research behind it. They keep refining it based on that research. And so it gives you a lot of information for a test that honestly doesn't take that long to administer. So this looks really long, right? Like 567 self-statements, but they're true false. So most of the time when I gave this to my college student clients, it took them 45 minutes or less. Sometimes if they were sort of overly critical, it might take an hour, hour and a half. But for most people, this is pretty quick, and the amount of information and the clinical utility of that information is beyond helpful. So you say either true as it applies to you, false as it applies to you, or you can leave it blank. And so if it's left blank, it's called cannot say. And that's because when they originally developed this, before they put it in like a Scantron form, it actually, they were cards with the statements on it, and participants just put them in piles. Like, yes, this applies to me, no, this doesn't apply to me, or I cannot say. That's gone now. And certainly people can just leave something blank on accident, but that is still what we call a blank. So there are different scales that assess different things. So there's the clinical scales that assess symptoms of disorders like depression and personality traits like introversion. And there are validity scales. So validity scales are really important, especially when you're working in, again, like a criminal justice setting, because this assesses things like over-reporting of symptoms. Sometimes people do that as a cry for help, or under-reporting of symptoms. So in child custody cases, there are actually different criteria they use for some of the validity scales, because they just sort of assume everyone's going to be lying. Because who wouldn't lie to try to get their kids, right? And actually, if they're not, then that's like a red flag, right? Because like, why wouldn't you be? So I believe your book uses the Green methodology, which interprets scores of 70 and above. I learned the Graham methodology, which is 65 or above. So that is what I am teaching y'all. Some sample MMPI items are, I would rather win than lose in a game. I'm never happier than when alone. And my hardest battles are with myself. This is an example of what your score report ends up looking like. They call it a profile. And this is a really condensed version. I think there are 30 plus different scores you get that each tell you something distinct about the person. So again, pretty minimal time for that much information. So in this case, all the validity scales are under 65. So that's telling us this person actually put in effort and answered as honestly as they could. And here you can say there's actually nothing on the cannot say, so they answered every question. That's good. And honestly, most people do now, particularly since it's starting to be computerized more and more. So it's harder to like accidentally miss one of them. All right, and then in terms of interpreting what all these are the MMPI 2 clinical scales. So this person is scoring high on scales 1 and 3, who's either both 65 or over. So this is 1, 2, etc. And those are related to what we'll learn about later in the semester as somatic symptoms. It's basically your psychological symptoms manifesting as physical symptoms. So they might be having many physical complaints, and that are, again, perhaps psychological in nature, because those two scores, and these scales have old school names that we don't use anymore. They're called hypochondriasis and hysteria. We don't use that anymore, and that's one of the reasons the MMPI-3 did update so much. You can see the highest score is depression. That is your number 2 scale. That's really high, so that's the first thing you would want to tackle clinically. He has some anxiety. If you look at the score on scale 7, again, old school term, it's called psychesthesia. It just means anxiety. And then scale 8 is actually high as well. You can see here. And this is actually the schizophrenia scale, but scoring at this level on this doesn't mean he's psychotic or experiencing schizophrenia. It could mean that he's just confused. And we know that confusion is actually a symptom of depression. So that's probably what's going on here. And then finally, this last scale is the social introversion scale. So he's peaking on that. He's a shy guy. And that tells us something about his personality. All right, so here's why I use the Graham method. So I was actually taught about the MMPI by Jack Graham and by Yossi Ben Porath, whose pictures are on here. They were my professors at Kent State. And they are, well, Jack is retired now, but they were and are among the, if not the leading researchers in the MMPI. And in fact, Jack helped write the MMPI-2, and Yossi wrote the MMPI-2 RF, which was a revision, and also the MMPI-3 that just came out. So I feel very fortunate to have sort of stumbled on a place where I got such excellent training. One of their postdocs at the time, Martin Selbaum, also taught me. I realized I should put his picture on here now because he's a big deal in this world now too. And he's actually at a university in New Zealand now, sort of spreading the MMPI love around the world. So certainly I was able to learn a lot from these folks. And one of the coolest things is that when the MMPI-2 RF came out in 2009, we were one of the first trainings because Yossi was there with us, so it was easy for him to do it, right? And Jack sat in the front row, and he wasn't involved in the development of the revision. So he asked Yossi questions about it, and to see an expert on the test asking questions was just amazing. So I feel very fortunate, again, to have gotten that training. And it's why I feel so confident teaching our assessment class that I offer in the fall. All right, so self-report inventories. And hang on just one sec. Got these allergies flaring up now that we actually have some more.
Dr. Myers, you accidentally muted yourself.
Oh, I did it on purpose so you guys didn't have to hear me blowing my nose, but thank you. Trying to spare you. Thank you, though. So self-report inventories are essentially like the MMPI, but shorter. So if you've taken part in studies here on campus, either through SurveyMonkey or Google Forms or gone in person to do a study, you probably have taken some of these because they're a big part of how we do research. Not just here at Wesleyan, but in general in psychology. So these focus on specific areas of functioning. So affective is going to look at your mood, your emotions. You might look at skills like social skills or other behavioral things. Cognitive are going to look at your thoughts and your assumptions. So this is just one example. This is a classic example, the Beck Depression Inventory. This is used clinically. And so not only is this helpful when you first see the patient, but oftentimes if you're doing therapy for the patient, you'll have them fill this out every week to see how they're progressing. It's 21 items, so it really doesn't take long for people to fill out. And folks just select the statement from the 4 that best applies to them. Obviously, this first item is going to be the thing we look at. first, you know, what is their suicidal ideation level? And I really like this inventory because it covers symptoms that aren't included in the diagnosis, but that will affect the person's life. So it asks about, you know, how is this interfering at work? And it asks things like loss of libido, right? And so people would be like, oh, why are we bothering asking mentally ill people about sex? Well, they're people, right? And we also know that, you know, depending on your relationship, this may interfere with your romantic relationships, right? So these are important things to know for people's quality of life. And again, there are, I would say, thousands of these types of things now, each measuring very specific things. All right, as we get more developed, more scientific, psychology has really integrated with neurology on a lot of research. So there are neurological tests that can be done to look at brain structure and activity. So for example, one that looks at brain activity is what you see on this kiddo here. So nothing's hurting him. He's just got some electrodes paying attention to what his brain is doing. And that's called an electroencephalogram. Gosh, I can't talk today. EEG. And if you've ever had an EKG for your heart, it's basically the same thing, but for your brain. And the output looks like this. So you basically see the activity in the brain. Now, that's great, but it doesn't actually tell you like where in the brain something might be going wrong, right? You could see like problems and patterns, and for sure EEGs are used for like diagnosing seizures or for sleep studies, but there are pieces you miss. And so that's where neuroimaging comes into play. And this involves taking pictures of the brain, and it can just be stationary, like an X-ray, or more and more we're using it basically it's kind of like a little video of the brain where a person is performing a task and you pay attention to what the brain is doing while they're performing that task. So the one that I think people know the most for this is the CT or CAT scan. This stands for computerized axial tomography. No, you don't have to know what it stands for, just know the acronym CT or CAT is fine. And it basically uses X-rays of the brain structure taken at different angles. So here you see example of CT images, and anytime you see something really dark or really bright stand out on the brain, it's usually bad, with the exception of these things that kind of look like kidneys or bananas. Those are found in every brain. We all have those, and they're filled with cerebrospinal fluid, and they help us with things like balance. So those are normal, but this dark patch here that you see in the lower right quadrant in all these images, that's not good. That was probably a bleed on the brain. And these bright white patches here were most likely TIAs or mini strokes, or actually with the scale of this, they might have been larger strokes. So it gives you a lot of really interesting information, and especially about if there's something wrong. Now, the MRI uses the magnetic properties of certain atoms in the brain to create a more detailed picture. So here you can see we can kind of like color code things, see how they light up. There's what's called fMRI that you can use to look at people's brains while they do those tasks. So this is really cutting edge. This is what a lot of people are using to do research about what the brain does when we're doing X. And it stands for magnetic resonance imaging. And this is really great, except if a person comes in unconscious and you don't have a medical history for them, you can't do one. And that's because this is a giant magnet. So let's say the person had, a screw in their knee, a plate in their leg, a pacemaker, heaven forbid, right? A deep brain stimulator. This it's not gonna like rip it all the way out of your body, but it'll move it around, right? And anytime anything's just sort of like moving around that's not supposed to be moving around in your tissue, it's really problematic, right? So if someone comes in, no medical history, they're unconscious, you would just do a CT to be on the safe side. and then maybe do an MRI later after you get that history. And fun fact about the MRI, it won the Nobel Prize for Medicine in 2003. And then there's the positron emission tomography, or PET scan. So this is a computerized motion picture of chemical activity. So the MRI looks at like brain function, the structure of the function of each structure. This is looking at chemical activity throughout the brain. It uses antimatter in its reading. It's really kind of cool and sci-fi. I did a paper about this for my chemistry class when I was in college. And so it really is, it feels like the future when you learn about stuff like this, right? And so this is a really cool picture, a really cool study here. So this is a study they did with cocaine users, in particular crack cocaine users. And so the top ones are someone who is not a user, and the bottom ones are someone who is a user. So you can see there's much less activity in the brain. And so if anyone, I don't know if this makes me old now, but there used to be in the 90s this ad on TV where they had an egg and they were like, this is your brain. And then they cracked it and put it in a frying pan. And they were like, this is your brain on drugs. So this is your brain on drugs. And then they would end it with, any questions? Yeah, I should probably just abandon that joke because it's old. All right, so those are things that psychologists would refer people to get. They're typically done, honestly, they're typically read by a neurologist, but they're typically performed by neurological technicians who are trained to do that sort of radiography, okay? Neuropsychological testing, however, is something that psychologists do. So these are tests that look for damage in your abilities, essentially. So we're, rather than looking actually at the brain and saying what's damaged, we're saying what can't they do now, or what is different about what they can do. And so we look at cognitive, perceptual, motor areas. So the biggest cognitive one is that intelligence test we talked about on Thursday, the Wechsler Adult Intelligence Scale, or WAIS. That's probably the only acronym from this chapter that's probably good to know. It's a series of tasks measuring verbal and nonverbal skills, and it's very carefully standardized, and you can compare it to well-researched standardization scores, so that's a big piece of it. And then perceptual can be things like the brief visual memory test, which is what you see here, where people are asked to copy these figures and then remember them and draw them from memory later. And there are more complex versions of that as well. Then there are motor things. So this is the picture down here is of the grooved pegboard. The pegs, they almost have like a Mickey Mouse shape that it had. And so they can only go in one way. So you have to twist your hand, and so this can help us, again, we have to like make sure they don't have other physical things going on like arthritis that would slow this down, but this can help us figure out if we're having difficulty sending motor messages from the brain. And there are so many more of these. Again, if you're a sophomore or junior, I'll be teaching clinical neuropsychology in the fall, and I'd be glad to have you all in it. We talk a lot about the types of tests that we just mentioned briefly here. All right, then there's clinical observation. So this is just used as a way to more directly examine behavior. And so here you see someone who's observing a kiddo in a classroom. And so this is naturalistic observation. You try to observe them in their everyday environment. So, you know, again, behind one of those one-way mirrors, figuring, you know, trying to be as unobtrusive as possible. Analog observation, you observe them in an artificial setting. So you'd bring them into your laboratory or your clinic and observe them there. And then self-monitoring, where the clients monitor themselves. So they would take home sheets and, you know, keep track of their thoughts throughout the week. Or, you know, when I was training people for eating disorders, we'd have them do food logs that would tell us like when they binged, when they purged, you know, what was going on then, to try to pick up patterns so that we could intervene before it started. So the next thing we're going to talk about, and again, that's just like a thumbnail overview of assessment, but we're going to talk about diagnosis, because diagnosis is going to be what we talk about for the rest of the semester. We're going to focus on individual diagnoses beginning next Tuesday, a week from today.
I have a question about self-monitoring and people with eating disorders. I know a person with an eating disorder. She's doing well now, but don't they lie in self-reports?
Yes. So you have to sort of impress upon them the importance of this. But yeah, when I teach my psychology of eating disorder course, I have my students read Portia de Rossi, Ellen DeGeneres, her wife's book about her struggle with an eating disorder. And she talks about how she kept a different food log that was real from the one she actually shared with her nutritionist. So yes, I think what makes the food logs easier that we use is that we actually explicitly tell them not to tell us amounts. We're just saying, like, what did you eat? And it's a lot more about what's going on around you. So like, who were you with? Were you alone or with others? You know, did you have a stressful time like that? What room in your house were you in? So that's really different than what they usually log. So I think that that's helpful. But yeah, that doesn't mean they can't lie, right? And so a lot of therapy for any disorder is about building that therapeutic alliance and building that trust and showing them the value of what you're having them do. Yeah, that's a really good question. Yeah, because they can lie about other things too. Like, I had a perfectionistic client who would use whiteout after homework, right? And so I started putting it on colored paper, so it'd be obvious when she did that. So yeah. Alrighty, really good question. Yeah, and we'll get more into the intricacies of each diagnosis and how we treat it and the problems that go with it as we go through the different disorders. That's really the bulk of what we cover in this class. That's awesome. So in terms of diagnosis, this is how clinicians label abnormality, or the technical term we use are mental disorders or psychopathology. And it allows them to compare clients, you know, like, oh, this person is like someone who has this disorder. But really, when you're doing diagnosis, it's idiographic. You're looking at that person in front of you and you're saying, what's going on with this person and how can I use that knowledge to help them? So a couple other definitions here is a syndrome. You'll sometimes hear that. It's just a cluster of symptoms. And then a classification system is a list of categories or disorders with descriptions of the symptoms and the guidelines for diagnosing, for assigning people to those categories. So a classification system is a list of disorders with descriptions of the symptoms and guidelines for essentially diagnosing people. So the very first classification system was developed in 1883 by Emil Kraepelin. We'll talk about him more when we talk about schizophrenia. And his work influenced both the International Classification of Disorders, or ICD, and the DSM, or the Diagnostic and Statistical Manual of Mental Disorders. And the DSM is what we use here in the US. It's used pretty frequently in other places worldwide as well. But the ICD is obviously the international standard. So the DSM was first published in 1952, and we are now on the DSM-5. So the DSM-5 lists approximately 400 disorders. So there's a lot of disorders out there. And again, clearly we're not going to get to all of them in this class, but we're going to focus on the ones that are most commonly seen in adults. And it describes the criteria for diagnoses. It describes key clinical features of these diagnoses and related features that can be present but aren't always present. And the DSM-5 revision is interesting because it adds an element. So we always had to give a categorical diagnosis, right? Once you give someone a diagnosis, it puts them in this category of people who are diagnosed with major depressive disorder, right? For example. But you also now have to do a dimensional component as well. And this is a rating of how severe a client's symptoms are and how dysfunctional the client is among various dimensions. So this is really important because it gets at the fact that not everyone who's put into this category of this diagnosis is having the same experience, right? So this, again, is even more idiographic, even more what's going on with this particular person. You can also include additional information, so they can provide relevant medical conditions, special psychosocial problems. So if you're treating someone for anxiety because they've just been diagnosed with HIV, for example, you want to include that information. So these are the lifetime prevalence of DSM diagnoses. So you'll see about a little over half the population never going to have a diagnosis. But then, you know, pretty consistently, people will be diagnosed with at least one or, you know, 3 or more disorders. So it's not uncommon for people to have more than one diagnosis. Is it effective? This is a big debate in the field of psychology and psychiatry. Those of you who took theories of personality with me last semester got to kind of live this when we did our simulation. So the validity of a classification symptom is how well the diagnosis actually matches what's going on with that person, right? The symptoms and the information that those diagnostic categories provide. Predictive validity is of the most use clinically. So if I give this client this diagnosis, what does it mean for how I treat them and how much that treatment will help them, for example? The DSM-5 framers also tried to ensure the validity of this edition by conducting extensive literature reviews and also running their own field studies. However, many are still concerned about its validity. So the effort to make this revision took more than a decade. There was a task force that was developed in 2006, but obviously stirrings before that. The DSM-4 revision, TR, they called it, came out in 2000, just to give you sort of perspective on this. And so then between 2010 and 2012, there were drafts online and they asked for feedback. The task force took the online feedback into consideration. And then, as I've mentioned before, I think this was published in May 2013. And some key changes included additions to and removal of diagnostic categories. They reorganized some of the categories. And sometimes they changed the terminology to try to more accurately reflect the scientific understanding of the disorders. So a big question in general in the field of mental health is whether just giving someone a label, giving someone a diagnosis can be harmful in and of itself. So obviously misdiagnosis is a concern, right? We don't want to label someone with a disorder that they don't actually have and like potentially label them with the stigma that might go along with that, or give them the wrong treatment that won't help because we're treating the wrong thing. And the major issue here is that as good as the DSM is, or as bad as the DSM is, you're still reliant on individual clinicians looking at their client, looking at the symptoms and matching them. So you're reliant on clinical judgment. And you can train people to be good at clinical judgment, but there are always going to be people who struggle with that more than others, right? Also present is the issue of labeling and stigma. So diagnosis may become a self-fulfilling prophecy. So for example, I had a client while I was on my residency that I diagnosed with a personality disorder. And when I shared that information with her, because she was in a counseling program, she knew what that meant. And she immediately took this as like, I'm fundamentally flawed and I'm never going to get better. And so we had to do a lot of processing around that issue. Some clinicians would like to do away with the practice of diagnosis altogether. That's a beautiful, beautiful idea, but doesn't work in our managed healthcare system. Like you need a diagnosis to get insurance reimbursement. What I've noticed is that a lot of these clinicians work in big cities where people will just pay out of pocket for therapy. And again, so they don't have the realities of managed care. More and more our treatments are focusing in more on symptoms than diagnoses. So I think we could do this, but it would require a fundamental change in sort of that industry, which I don't know. Maybe the Biden administration will get some of that moving. I'm not super optimistic since the Obama administration couldn't in 8 years, but we'll see, we'll see. All right, some problems with the DSM. It relies very heavily on categorization. Even with that dimensionality of severity, you're still putting someone in a box, basically. And as we'll see throughout the semester, you know, there are examples of disorders where you can either have 5 of the symptoms and be diagnosed, or have 9 of the symptoms and be diagnosed, and you would get the same diagnosis, right? So clearly some issues there. So disorders may not be boxes we can put them into. Instead, they may fall along a continuum. So for example, there are people who have problems with eating, stress eat, occasionally binge eat, things along those lines, but they don't meet full criteria for an eating disorder. It relies too heavily on labeling and ignores uniqueness, people argue. And labeling itself may just also be problematic. And there's a classic study by Rosenhan called Being Sane in Insane Places. And so Rosenhan, this would never fly today. This is why I'm laughing. So he had people, including his graduate students, go to psychological inpatient centers and claim that they were having a psychological disorder. So he called them pseudo patients. And they all gave the same story, that they were hearing voices saying existential things like hello and thud. And what they were all admitted. And what he found is once they were admitted, they were not respected. They were not treated as humans. They were treated like they were insane, even though as soon as they got in, they stopped reporting any symptoms and just act like a normal person. Everything they did was molded or like used as confirmation bias to fit that diagnosis. So for example, one of the pseudo patients was taking notes for the study, and the nurses were like, oh, that just shows like how paranoid they are. And meanwhile, the other patients were like, you're a researcher, aren't you? Right? So it just shows the bias that can come from labeling someone and how that can put clinicians in a box that they have a hard time getting out of. It may reflect gender and cultural bias. So for example, premenstrual dysphoric disorder, which we'll talk about a little bit later, is a mood disorder that is pathologizing PMS, basically. And there's an argument to be made that there are women or people with uteruses that experience these essentially like depression level symptoms when they're on their period. But the way that the symptoms are written, really, you could diagnose any person who has a period with it. There are things like, I crave certain foods, I feel bloated, right? And so you would hope people use their clinical judgment and only apply this in those situations, but certainly is pathologizing just a normal part of menstruation. And there are cultural things. Let me mention cultural things real quick. So there are these culture-bound syndromes that we discuss, and they're all from non-Western, maybe indigenous cultures. And people have made arguments, for example, that something like bulimia nervosa should be considered a culture-bound syndrome, but for Western culture, because that's where we see it, and we don't see it emerge in non-Western cultures until we introduce Western media. But they're like, no, 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 no. So again, some xenophobia, I think, and racial and cultural biases in how this is constructed. There's often overlap of conditions in one individual. So we'll talk about how symptoms or disorders from different categories can have similar symptoms. And it can be difficult as a result to distinguish between disorders. So in theory, you could have 2 different clinicians analyze the same patient, assess the same patient, and come up with different diagnoses. So again, that's the rest of the semester. We're going to be talking about that. So this is just a nice overview. Next, we're going to talk again surface level about treatment. As we talk about each disorder throughout the semester, we're going to talk about treatments for that disorder in a lot of detail. And the disorders we're going to start with are the mood disorders, so depression and bipolar disorder. And there's a whole chapter on treatments for those just because they're so plentiful. There are lots of different options. So we're going to spend a lot of time throughout the semester talking about these. So this part is basically just kind of like a thumbnail sketch. So one of the big questions clinical psychologists in particular ask in research is, how helpful is this treatment? Is this therapy that we're doing actually helping the person? And more we're starting to say why, or what piece of that therapy is actually helpful. So what we do to do this are look at whether it's effective or it's efficacious, and effectiveness studies. So looking at whether something is effective is trying to determine if the therapy actually reduces symptoms. So effectiveness studies look at, does this treatment reduce symptoms? So is it actually making a difference for that individual who's in therapy? Efficacy studies are what a lot of clinical psychologists focus on because they're sort of like a baseline before you can get to effectiveness studies. And so these contrast a kind of therapy to a comparison group. So they're an experiment, but for therapy. So maybe you do, cognitive behavioral therapy versus interpersonal therapy, or therapy versus medications, things along that line. Or, people have also looked at therapy versus medications versus the combination of therapy and medications. If it's a new treatment, we try to have a control group. As we mentioned in our chapter on research, these are hard to figure out in psychology, like what's a control for therapy. So a lot of times what we do is called a waitlist control. So let's say the therapy is 8 sessions, right? We'll contact everybody, and then the people who are in the control group will tell them, okay, so you'll start your therapy in 8 weeks. And then we compare the people who are starting therapy now with those who are still waiting for therapy. Because we know there's some hope when you're told, hey, I'm going to get some therapy. And so we want to make sure the therapy we're doing actually improves people beyond that. Smith and Glass is a really famous study. So they did a large-scale study where they looked at a lot of these efficacy studies. And they said that the average study showed 0.68 standard deviation superiority of treatment over control, which is pretty good. The average client who was treated was 75% off better than untreated controls. And they were, at that point, all about the same effectiveness. I think that study was done in the 80s. I think if you replicated that now, we'd find some differences because we have really honed in on like what's working for which disorder and why, much more so than we had back then. But at the time, this was called the dodo bird hypothesis, and this comes from Lewis Carroll's Alice in Wonderland, where the dodo bird says, all have won and all deserve prizes. So you'll hear that thrown around in clinical settings sometimes. The Consumer Reports study is another really interesting one. So if you're familiar with Consumer Reports, you use it if you figure out like buying a car, which one's the best one? If you're buying a vacuum, which one's the best one? Well, they did it for therapy. And so they looked at things overall and found some consistent things across different types of therapy. So treatment usually worked. Hey, that's good, right? That's what we want. We want to be helping people, not just doing nothing. In particular, treatment by any kind of mental health professional. Doesn't matter if you're a PhD, master's, social worker, counselor, clinician, what have you. At that time, they found long-term therapy produced better results than short-term therapy, particularly if the short-term therapy was determined because of insurance coverage. So if your insurance said you can only have 4 sessions, but your therapist thought you needed more, but the insurance won't give them. They found that didn't work as well. At that time, they found no difference between psychotherapy alone and psychotherapy plus medication for any disorder. And this is all like self-report of people who have been through the treatments, right? And then they found that psychologists, psychiatrists, and social workers did equally well. And at that time, they did better than marriage and family counselors. I would say, given the rigor of MFT programs now, you would probably find something different. They found that if you go to your family doctor for help, if you're suffering from, let's say, depression, that works pretty well in the short term, but over the long run, you didn't do well at all. So it's really imperative, and most family doctors or primary care physicians now are really good at this, that they refer you to a psychologist, a psychiatrist, someone who's trained in these types of things. That becomes very important. Another really good factor, I think, is that Alcoholics Anonymous, AA, which is, unless it's done in an inpatient setting, typically entirely run by the people themselves. There's no professional there. They did very well in average improvement. Now, there are some caveats to that we'll talk about later in the semester. AA does have a spiritual component, and if that doesn't resonate, it doesn't do as well for that person. But it's nice to know like a self-help group could work as well if, again, no cost at that point, not billing your insurance. People who shopped around for the best therapist fit for them and who were actively involved in their therapy did a lot better than people who were passive recipients and just kind of went to the first person. And the dodo bird hypothesis did seem to be confirmed in the study that no treatment was better than any other. And respondents whose choice of therapist or duration of care was limited by their insurance did worse, as I already mentioned. So yeah, essentially, treatments tend to work, especially when it is dictated in part by the patient, right, and their provider, rather than managed by their insurance company. So a big push right now is to work towards what are called empirically supported treatments. You'll hear these also called empirically supported therapies, or there's lots of different acronyms. But essentially, these are treatments that have efficacy studies showing that they work. And typically it has to be, I believe, at least 3 studies, but most have way more than that. And actually, I'm going to real quick do a screen share for y'all. There we go. Now I don't look as short. And show you a great resource for this. So give me just a sec to find it. And I think I might have actually shown you all this at the beginning of the semester when we were talking about your paper, but it's always good to kind of re-show it to you. So let me do a fresh screen share.
Well, you're doing that. Can I ask you a question?
Of course.
Is there any push from therapists and counselors to get rid of the insurance system for mental health? Because it doesn't really seem to be helping anyone.
Yeah, there have been pushes and people advocating for either getting rid of the system or revamping it for as long as I've been involved in the field, and I'm sure much longer than that. So for example, the American Psychological Association has a whole component of their staff that are essentially just lobbyists. And like their office is in DC purposely so that they can go and talk to Congress people about getting what we call mental health parity. So at least getting mental health paid for the same way like physical disorders are paid for, right? But yeah, there is, and then that's why you do see some people pushing for like even doing away with diagnosis. It would be so great if we could, to be honest, and like anyone could get the treatment that they wanted and that they needed. Because like we haven't even talked about inpatient treatment in this day and age. Inpatient treatment, it's nearly impossible to get your insurance to cover for as long as you need. So patients that need to be in there longer, their families go bankrupt, basically.
Yeah, I'm taking the ethics and psychology class, and we were talking about clinic and clinical work. And I was thinking that it's a very big ethical issue. The fact that if you can't really pay for it, or if you don't have insurance, you just don't get care, or your treatment gets suspended. That's ethically, that's not right.
Yeah, and I was trying to find. I'm not going to be able to find it quickly, but this past summer actually, and this has been done for other disorders too. But the International Conference on Eating Disorders had a large-scale study done on the economic impact of eating disorders. And again, eating disorders are fairly prevalent, but nothing compared to like depression, right, or something like that. And it's like in the order of billions of dollars a year that our economy loses from like time spent of people out of work, things like that. And so the thought is by doing studies like that and taking those to, Congress or whoever, then you can see like, ooh, the bottom line. It's sad that we have to motivate people with that rather than like these people need help them. But that's just how our capitalist society works, right? But yeah, more and more people are trying to find ways to like appeal to those folks that like, okay, you won't listen to like, let's just help people. Here's how this is negatively impacting your bottom line. So a lot of disorders, people have been looking at that and trying to advocate in that way. But yeah, it's horrible, to be perfectly honest. It's awful that unless there's a low-cost clinic in your area, and heaven forbid you don't have insurance, right? So some of you have heard me say this before, and I might have even said it whenever the syllabus, but I had a client I saw who didn't have insurance that covered mental health care. And luckily her family was well off enough she could afford it. But, I didn't set this, the facility did. She paid $175 an hour to see me, plus another $100 an hour for a facility fee. And this was just for outpatient therapy once a week. And it's just like mind-boggling to me how we expect people to pay that, right? And like eat. So yeah, there's a lot of people within the mental health field who really want to work on making things more accessible to other individuals, because we know, for example, people in poverty, BIPOC individuals, so those of you who don't know that acronym, Black, Indigenous, people of color, have much less access to mental health care. A, people aren't putting their offices there. B, often they don't have health insurance, right? If you work a part-time job, and a lot of retail jobs will purposely keep you part-time so they don't have to pay you benefits, right? Like when I worked even as like a college student in the summer, retail, they would purposely give me like 39 hours a week so they didn't put me over and they didn't have to start paying me benefits, right? Which, like, I was a college student, so I was like, fine. But imagine if you were, someone trying to care for your family. But yeah, so there's a big push within APA right now to recognize not only these issues, but also the issues with like physical care within the pandemic. So we know that the pandemic has hit people of color and people in poverty at much higher rates, partially because a lot of those people work in frontline jobs, retail jobs as nurses, things along those lines. And partially because, again, access to medical care is not great. We know that there's research that shows that women and people of color are less likely to be believed when they present for any kind of treatment, including physical. So let me actually throw the hashtag down here for you all. It's called Equity Flattens the Curve. And you'll sometimes just see it abbreviated. But they've been doing a lot of work in APA, on Twitter. I was part of like hour of tweeting about this at one point, which doesn't seem like much, but it was like the most my tweets have ever been like liked and retweeted, so people were paying attention. But I was trying to raise awareness and trying to really advocate. And so I don't know if any of you all have signed up yet for your COVID vaccine, for example, but when you do that, there are demographic questions. And essentially because of the advocacy, not only by APA, but other organizations, they have to keep track of who they're giving the vaccine to, and they are going to have to sort of prove that they're giving it to everybody equitably. And that's not something that has been tracked in the past. So the problem, of course, also, this is like a sidebar, but is that because of the history of them being ignored, people in poverty, people from marginalized groups are less likely to get the vaccine because they don't trust it. I mean, and who can blame them, right? If anyone knows about the Tuskegee study, horrible, horrible study that was done for years where they tested what happens in syphilis. And so they just used Black men and like they had a treatment for it and they just didn't give it to them to see what happened. So of course, people of color and people in poverty and other marginalized groups don't trust the vaccine, right? And so that's why you see people like Spike Lee actually, when I think on social media live when he got his vaccine, and why Kamala Harris did it is because they're trying to get it out there that like, okay, this is safe for us too. Yeah, it's a huge issue, not only in mental health, but physical health. And more people are standing up and taking notice. And, but again, we got to work to change the system. So that's why it's good that, again, APA has their office right in DC, so they can help with that. Yeah, really good question. This is something I'm pretty passionate about. As you can probably tell when I'm talking about it. So I've been fairly involved in some of this. All right, so again, I think I did show you all this earlier in the semester, but this is the Society of Clinical Psychology, Division 12 of the American Psychological Association. So it's made up of clinical psychologists. And what I like about that is that there's not an inherent bias. So admittedly, my major organization that I go to conferences for is the Association for Behavioral and Cognitive Therapies. So they're very biased. They're gonna only really be touting behaviorally based therapies, right? This is not that. This just looks at the research and says, based on the research, what works. So you can do it by diagnosis, which I think is really great. So like, again, I do eating disorder. So let's look at anorexia nervosa. And what you'll see is it says, okay, these are the two. There's only two that work for anorexia nervosa, right? And in fact, family-based treatment works better than CBT, to be perfectly honest, which is, you know, rare for a CBT person to say. And you'll see they update it all the time with more information. And then let's look at something like depression. Well, there's a lot more research money and funding and just honestly a lot more people with depression. So you'll see there's a huge list of things that are shown to treat depression. And so you'll see that like they need to reevaluate as they go, which I really like. You'll see there's, you know, the cognitive behavioral analysis system. So this is a meshing of CBT and psychoanalytic therapy, right? There's interpersonal therapy. There's short-term psychodynamic therapy. So again, I really like this because it is not, oh, it's only, you know, our organization's pet thing that we like, but it just shows you based on the research that's out there, this is what works. And again, depending on the disorder, you'll see fewer or more treatments. So something like borderline personality disorder, which is pretty complex to treat, you know, again, like anorexia, pretty short list, right? And again, you know, really honestly, only the first one is what I'd recommend just based on what I've read. And so, but the cool thing is they also include things like irritable bowel syndrome and fibromyalgia, which are physical disorders, but have stress-related components to them. And here you see pain due to rheumatoid arthritis. And there are therapies that work for those because of the stress-related. And there's actually psychological things you can do for physical pain. And that's really a nice new subspecialty in health psychology. So I really like this site because of that reason, that it just puts it out there and says, this is what has research support, right? It's not biased and it's honest. It tells you like, okay, these worked, but they need to be reevaluated, right? Headache, back pain, things along those lines. And you'll see there are some disorders that might not be on here, right? And so we'll talk about those throughout the semester too, like antisocial personality disorder is not on here because we don't have any treatments that work for it yet. It's really hard to treat someone who's a psychopath and thinks there's nothing wrong with what they're doing. So yeah, so again, it's sort of the wild, wild west of figuring this stuff out. And we're just trying to apply science to it. And psychologists, especially clinical psychologists, have been doing a pretty good job with that. But we still have a long way to go too. Alrighty, any questions that anybody has about anything I just covered or about the exam? So again, for those of you who came in late, sign in just like you normally would for class on Thursday. Do try to be on time just because I want to start the exam right away. I'll wait like a minute or two, but I don't want to hold people up. And then I'll open it up on Blackboard. I'll show you where to find it. And then you can take it and then use the chat to ask me questions. And then one thing, and I'll say this again on Thursday because people don't necessarily remember, is like as soon as you're done and you submit it on Blackboard, you can just leave. You don't need to tell me you're leaving or anything. But basically, I'm just there like I would be in class. Like think of this as me sitting at my desk at the front of the classroom, and you can come up and ask me questions. And the coming up and asking me questions is the chat. So. Alrighty, I'll hang around a minute or two in case anyone does have individual questions, but then I do have to scoot right around 10:45 because miracle of miracles, I get to go get my COVID vaccine at the convention center. So, again, I'm here for you. You can definitely email me between now and Thursday morning as well. So everybody have a good day.
Bye, thank you.
Dr. Myers, I had a question.
Sure.
Was there a certain format that you wanted me to email you about declaring my major, or when I send you the
Send
message?
me an email saying I want to declare the BA in psychology, and then I'll write back and I'll CC the registrar and say I'm agreeing to be her advisor for this.
Okay, so for my English major, there's a concentration. Is there a concentration for?
Nope, we don't have one. It's just the BA or the BS. So
Okay, thank you.
no problem.
Okay, I also have a few questions.
Great.